Hey there, and welcome back to the Complicated Kids podcast. I'm your host, Gabriele Nicolet. I am a toddler whisperer, a speech therapist, and a parent coach. And today I have Gilly Kahn with me. Gilly, welcome.
Thank you so much for having me on your show, Gabrielle.
I'm going to have you tell everybody the title of your book and the kind of work that you do, because we are going to dive deep, probably, into teenagers today. So take it away. Who are you and what do you do?
Okay, yeah. So my name is Dr. Gilly Kahn. I'm a clinical psychologist. I specialize in neurodiversity and emotional dysregulation. And the my main clinical group that I work with is teens. So I do a lot of work alone with teens, but in my practice, I like to also include parents. So a lot of navigating, issues between teens and parents. Um, and I'm also a writer. So since I was very young, I've loved creative writing since middle school. I used to just write stories for fun. And so when I got to college, I double majored in psychology and creative writing. And then I had to kind of put most of my eggs in the psychology basket because it's just very time intensive. Since I first got a master's in experimental psychology and then I got a PhD in clinical psychology. So writing was kind of on pause, even though it was still a huge passion of mine. And there were like intermittent moments of like submissions but it wasn't something that I could really sit down and focus on. And now that I'm finally established as a clinical psychologist for, a few years, I've been able to sit down and just say, okay, I'm going to start this again. And that's when I started working on my debut book, which is about ADHD and emotional dysregulation in women. The title is going to be Allow Me to Interrupt, and it's expected to be out in 2026. So I'm really excited about that.
Allow me to interrupt. I love it. Okay, so speaking of interruptions and teens, let's go there and let's talk about. And we don't have to stick to ADHD necessarily because emotional dysregulation is something that occurs across conditions, but certainly anybody with an executive function challenge is going to experience emotional dysregulation as one of those challenges. Yeah. Do you want to
Absolutely.
kind of
Mhm.
talk about, let's set it up a little bit here.
Yeah, sure. Okay. Yeah. So I think you actually brought up a really good point. You said that emotional dysregulation is just tied to executive function. And it's one of the subscales on various executive function measures. When you go and you complete testing, there's usually an emotional regulation, like a scale. And the reason for that is because, you know, to talk about ADHD, but also if you think about just the conceptualization of like behavior problems more generally, people focus more on the getting out of your seat and how does that interfere with academics. And a lot of people sort of default to relating that to school.
Mm.
And they, I think, for the most part, neglect to give enough weight to what happens at home.
Mm.
And I think that's why a lot of girls with ADHD don't get diagnosed early because parents will come in to specialists or just pediatricians and they'll say, we're really struggling with our daughter's emotional regulation at home. And so they immediately kind of turn to anxiety or depression or the more like obvious emotional conditions. Whereas it's exactly what you said. It's very closely tied to your ability to inhibit impulsivity. Because if you are impulsive, then you're going to act without thinking or, kind of act very quickly. And if you're feeling emotional, that just exacerbates that.
It's so interesting the way you just described this. And I know this is true, but it just like really bubbled to the surface for me, which is it's so sexist.
It is.
It's
Yeah,
so sexist and it's baked into the medical system. And again, this is a
it is.
surprise to no one. And yet, when again, when you were talking, it was just like so surface level, like, oh my God, there it is right there.
Yeah. And the truth is that, I mean, like, that's why I gave my book my title. And actually, it's very much inspired by my love for writing. And the structure of the chapters is kind of like each title is inspired by Shakespeare's The Taming of the Shrew. So the first chapter is If I Be Waspish, Best Beware My Sting.
Nice. I
And
love
so
it.
I talk about, yeah, like how society mislabels girls and women with ADHD. And it's a problem because they walk away internalizing those mislabels, like being rude or, shrewish, I guess to say it in Shakespearean terms.
Yeah, yeah, yeah.
Um,
This
and
happens in autism as well. So,
yes,
listeners can go back and listen to the podcast with Sarah Wayland and Donna Henderson. There's also a podcast I did with Sarah Bybee Fisk on ADHD in girls and women in particularly. And this is, yeah. And then, so there's this socialization component, then there's this misdiagnosis component, and all of that. Then no wonder we have anxious girls at some level.
absolutely. Yes. And then their teens and their hormones start to kick in, I mean, the criteria, like you said, like it's funny because girls and women, like we're so sensitive. So it's like I feel this ping in my heart anytime I want to say something that sounds like I'm blaming someone, but it's sexist. So one of the criteria for an ADHD diagnosis is that the symptoms must be present before age 12. And before it was younger than that.
Mm.
And so, they basically, researchers and the professionals who write up the criteria realized that we were missing a lot of girls. So they pushed up the age to 12, but then that's still a problem because a lot of the girls that I see, their symptoms are different because we have hormonal fluctuations that continue throughout our lives once we hit puberty, and it's different than in boys and men. And so these teenage girls, whereas maybe they struggled less with, or less obviously, with staying seated in class or paying attention or regulating their emotions, now their hormones are in flux and the ADHD becomes even more obvious. So maybe the symptoms were not so obvious before the age of 12, but now that they have their period, then they're much more obvious.
This is so interesting, and this is something we don't talk at all about. I don't really think, which is the fluctuations in women's cycles, and this idea that, like, you can go into the personal growth and development literature to find some of it some of the time, but women are on a 28-day cycle, or whatever your cycle is. Men are on a 24-hour cycle, and yet, so the whole kind of work culture, school culture, life culture, Western culture is geared on a 24-hour day,
Yeah.
not a 28-day month. And
Yeah.
so if you, and the thing that you're describing here is kind of this low level of, I don't want to call it dysfunction, but I will, just for the illustration of the example, right? It's like this low level of ADHD that's kind of in background. And now we've got additional
Right.
biological
A dip.
functions, and we've got a dip happening, and that's where we see a clinical presentation, is I think what I
Maybe.
hear you saying.
Yes. Yeah. Yeah. Or it's a more obviously disruptive presentation that maybe would meet the current criteria, which were developed on mostly boys.
And I can hear myself, even in my own brain, saying, well, that's just something that she has to deal with. I mean, like, I can hear the
Exactly.
internalized sexism in
Yeah.
my own head.
Yes. Yeah. Like I'll just suck it up. I even had the thought actually. So I am subscribed to Dr. Russell Barkley's channel on YouTube, and he recently released a video where he talked about hormones and just I like to listen to what he has to say because it's like it's easy for me. I listen and I get an instant update as to what was just published and what's new. And so it's true what you're saying that this has been neglected in the literature. And so he said that there was I think she's a psychologist, but there's a psychologist who presented her data at a conference. So it's not officially published in an academic journal yet, but there was an article like in the media that was published about her results that are going to be published soon. And this was the first study to actually track women's ADHD symptoms in concert with their cycles. There were like, I
Hello.
think, I know, yeah. And it's crazy that it has taken this long for someone to do this. I mean, she wrote like a theoretical, like a paper with a bunch of hypotheses in 2023. And basically, whatever she hypothesized, obviously, like is what she found. It's the kind of thing where it's like we all know this to be true, but no one has actually, published the data. And it's not, I don't think it's specific researchers' fault because there are people, women who are ADHD experts who have been talking about this for years. I mean, in understanding girls with ADHD, by some of the leading researchers focusing on ADHD in women, they talk about this. And I think the reprint of the book was in like 2015. So it was 10 years ago. And only now are their data being published. So there just wasn't probably any support for them, like any funding
Right.
until now.
Right. And so there's a great book that I like to encourage people to read. I actually couldn't read it because I would get so enraged, but it's called Invisible Women,
Oh,
Data Bias in a World Designed for Men. So, and, and, and this is relevant because, and I'll just keep it to here because there's so many examples of how, like car safety, they were not required to use female bodies, female dummies in car safety
yes.
testing until like, I don't know, 1990 something. It's ridiculous. But as regards
I
medication,
mean, I believe it. I
yeah,
believe it. But yeah, I understand your rage.
it's insane. So like I couldn't actually read the book, but for those of you who like the data, for those of you who want to understand like how insidious this is, let's just take ADHD medication. I don't know that anybody knows exactly how the effects of ADHD medication differ from females to males. Like,
Exactly.
have people done that
Yeah.
research? I don't know. And are doctors aware of that when they're prescribing?
Yeah. I'm sure. Okay. So I'm sure that there are studies that compare boys and girls, men and women. The problem though is it all kind of goes back to the first domino in the chain. I talk about this actually in an article that I published in a magazine. It was like limited edition. I don't know if there's like but this is
Oh,
it.
yeah,
Yeah.
ADHD magazine.
But we're actually gonna have, so this is not being sold anymore. They discontinued it like at the end of December. But we're publishing a female version of this. So like ADHD in females,
Hmm.
and it's gonna be really good. Just, I don't know, just putting it out there.
Wow.
But anyway, I have an article that I wrote in here about exactly what we're discussing and about why this is still a problem with women being just accurately represented in healthcare research.
Mhm.
And the problem is that, I think that the NIH was looking for a way to enforce that,
Mhm.
to make sure that, first of all, there are equal groups of men and women, of males and females in studies. And so researchers were listening to it, like in Hebrew you say like khafif, like halfway. Like they, maybe they did it in half of the studies. So they increased, the percentage of studies where there was equal representation for males and females. But then the problem was that they didn't do the same thing for animal studies. So they were using, mice that were all males to study the effects of medication because they deemed that, the female mice were more complicated because of their hormonal cycles.
I mean,
No, wait, it gets worse. It gets worse.
Oh no.
So, right? So there, that was a problem that, people were just like, they weren't even noticing. So then the NIH came back and they said, you have to do this in animal studies too. And so then people were like, okay, and they started to maybe do it a little bit more in animal studies, but it still doesn't significantly like move the needle. And so listen to this. So even though they're increasing the number of females in their studies, they're not even, it's mind-boggling. I'm sorry, this is gonna make you angry, but like they don't even compare the two. They have the data, but they don't statistically compare the males to the females in their studies. So it was like, they increased the number of studies with greater representation of females, but even with doing that, they don't even talk about the females, like they're separate from the males
Right.
in the study and look at them uniquely.
Which is, it's actually making the data bad for everybody. So
Yeah.
that's completely bizarre to me. Okay. We could like churn here all day. Let's bring it back out into the world. Because I want you to talk a little bit about your work and sort of so this is like the soup we're all swimming in. This is the water we're all swimming in, is kind of this world. How does that manifest in behaviorally, in emotionally, in terms of what you're seeing in your practice with the girls and women that you see? And then let's hopefully maybe get to like a couple of things that people can do about it.
Yeah.
So how does it
So
show up?
from what I've seen, at least like from the, teenage girls that I've worked with who, I've sent them for retesting because they come in and they're diagnosed with like anxiety or anxiety and depression. Sometimes even the parents will say, oh, I'm going to take her back to the same assessor. And I will tell them, normally, like, I know this because I'm in the field, we're biased. Like once we say, oh, I think this child has this, or I think this teen has this, I've already ruled that out. I've already thought about it and ruled it out. They're less likely to come in with an open mind and, to diagnose like ADHD or something else that's suggested. So, in my opinion, usually when we're in this situation, it's better to go see someone else and get another opinion and to share the evaluation, but to see someone else, preferably someone who specializes in ADHD in girls and women, because someone who specializes in ADHD is not someone who specializes in ADHD in girls and women. It's the same thing with autism.
Mm-hmm. Mm-hmm. Yep. And that's
Yeah.
in Donna Henderson and Sarah Whalen's and Jamel White's book. They talk about exactly what you're talking about, and I'm sure you'll talk about it in your book as well, which is it looks different, it presents differently. You have to be aware of how it presents differently in order to even have it on your radar in the first place. And I appreciate what you're saying in terms of a second opinion for a reevaluation if we think that something isn't quite holding together. We've maybe received a diagnosis, begun some treatment, and it's not working. Okay, maybe we're not looking at the right thing.
Yeah, exactly, exactly. Or they'll say, let me give her anxiety and depression, put her through therapy, with me for a year. And then if she's not doing better, then we can reconsider. But the reconsideration, from my experience, is not a very serious one.
Mm.
It's much better to go see someone else. It's like they could go through therapy for a year and then they'll say, oh, still not. Let's be conservative. And that bothers me because then this child is going another year suffering and I see it. It really is suffering and it affects like the entire family because then the family misperceives it too. I mean, like I can tell you stories that are very common situations where like teens will butt heads with like teachers. As a teen, it's like maybe you're not like thrashing or throwing a full out tantrum, but you're disagreeing with the teacher and it's coming out the wrong way. And girls with ADHD struggle with social skills and then they're mislabeled as like oppositional and then they end up getting an F. And it's just like a whole cascade of unfortunate and unnecessary events.
This is my pet peeve, and because it's my podcast, I can say it here. Oppositional defiance disorder or oppositional behavior or any acronym or term that uses the term oppositional should be thrown in the trash.
I agree with you.
Never
Yeah.
used
I
again.
hate it.
It's
Yeah.
terrible. It's coming from an authoritarian, limited, like patriarchal, to say the least, but that's like the least of it, worldview in which we're not, first of all, we're not helping, we're not describing anything, we are labeling in the worst possible way, and it's simply not helpful. And so
Yeah.
I just, if you're listening to this, your child has a diagnosis of ODD, throw it out. Figure out what's underneath that. What's probably
Yeah.
underneath that is a neurological, a nervous system disorder that is preventing them from behaving, in air quotes, in a way that they would like to behave but cannot. Sorry.
Yes, yeah. Yeah, I've also been in situations too where like the parents will want to go through insurance and so they'll get someone who's not a specialist and then they put like a diagnosis of ODD at the end of their evaluation. And I sit down with the parents and I'm like, you call this person and I will call them too and we need to remove that because if a school sees that, they're going to label your child and I know your child and I've been working with them now for a long time and they don't have ODD.
Yeah. Yeah. I mean, nobody has ODD. Like literally nobody.
Okay, fine. I mean, look, if it's like, if you look at someone who is like a serial killer, and then you look and you backtrack to their childhood, it
Sure.
makes sense that some kids have oppositional defiant disorder, and then it leads into conduct disorder, and then it leads into antisocial personality disorder. Yes, I can see that.
Yes. And I would say that before that, they had a nervous system disorder that was triggering those behaviors.
Yeah, I
That's
agree with
like a
that.
neurobiological condition that's now being exacerbated by their environment. And people can argue all day long, and and I take your point as well. In extreme cases, maybe we do want to have it. But certainly for the people that you're seeing in your practice, they do not have this condition.
Yeah.
And you get it taken off. Okay, so reevaluation, I love that. Super practical tip that parents can use. Tell us like a quick story of, I don't know, do you have like a client story that stands out in terms of,
Yeah.
yeah, tell
So
us.
I have one client who I talk about in my book. I named her Anna in my book. So she's kind of like the star because I open up the story with her. But I think she's just a prototypical like example of a teen girl with ADHD who got diagnosed, and it really did make a very positive impact on her. But initially she, went through the kind of the prototypical, testing where she was diagnosed with generalized anxiety disorder and oh, and a math disorder too. That's another thing. I mean, they're highly comorbid, the
Yeah,
specific learning disorder in math.
yeah,
And I think I have it undiagnosed
mm,
too.
yeah,
So I really identify with Anna. I think we're very similar.
mm,
And so she got those two diagnoses, and basically, I was seeing her for therapy. She went through a few years of therapy. It was with someone else before me, and then with me. And she wasn't really, getting better. There was something that was still getting in the way. And she came in with just feeling very ashamed
mm,
because when she was younger, she would have those outbursts
mm,
where she was very emotionally dysregulated at home. It was more extreme for her, like than some other girls that I've seen when she was a kid, like in elementary school, and she used to, have trouble like in school because of that. And basically, the way it was rationalized or understood is like, oh, she's anxious and she's got challenges, like academic challenges at school with math. And so that was leading to her acting out, which could be the case, but because, she did get like intervention in school for math and it was helping her. And she was in therapy and still there were issues where she would get really riled up
mm,
and get into these big arguments, especially with her mom. And I've seen them too, like throughout therapy with her, and they aren't typical.
mhm,
Like when she has a moment, it's very big, and it takes her time for the emotions to come down.
mhm.
And so that's another reason I think it's so important to include parents in therapy because if there's a big problem with those interactions at home, like the parent needs to know what to do and to understand what their kid is going through so that way they can be effective and, diffuse the situation
I
and
think
help
that's
her.
really interesting because I don't know, you tell me. It seems to me that most clinicians would not be having parents in the room
Oh, yeah.
with teenagers.
Yes. Yeah. I hear a lot of clinicians say that. They say that, oh, well, when they're teens, they want their privacy. And then, in my opinion,
Yeah.
I think, I don't want to be around forever. I mean, I wouldn't mind it. Like, I love my clients, but I'm not going to be around forever. And, their parents are going to have them around, until they die. So, I mean, like, they're going to move out and stuff, but you still are their parents. You want to support them through their life and understand your child. And also, why not get the teen to like love their parent and want to share things with them and feel comfortable with them? Like I feel like it's doing a disservice. You're, if anything, like kind of forming more of a wedge by just talking to the teen. And it's not, forcing it on them. It's slowly, gradual.
I totally agree with you. I mean, and the other thing is, if there are siblings in the house, now you're building capacity. I just told somebody this the other day. I was like, I used to go into the home, just deal with the child and leave. And that's, giving somebody a fish for a day and they'll eat for a day,
Yeah,
right? When you build
right.
capacity, you teach them to fish. That's for a lifetime. That's for the rest of their relationship. Now they've got some skills that they can draw from. And I think it's better. It's harder. It's harder.
It is harder.
It's maybe a
Yeah,
different set of skills on the
right.
part of the
It is
clinician,
harder.
but I think, yeah, more effective.
Hmm.
So Anna, okay, so Anna came to you and you saw them together. And so what happened?
Yeah. And so actually it was funny because the first session, when she came in, she had one of those moments. So she came in and we were talking about, it was the intake, it was information gathering and just asking about how were things when she was younger. And so the mom was sharing that, she used to have these episodes at school where she used to like throw things or when she got really angry, it was explosive and disruptive. And so I think it was around that moment that she just kind of like completely burst out of the room, like just got up and left. And I was just like, okay, like this is my first time interacting with this person. And I was just like, there's no way she's coming back. But it was a challenging intake session. And so she did come back like the following session. And I sat with her alone. And one thing I do with teens is I like to play games while we're talking. So we'll like play Moncala or Jenga, and that makes them a little bit more relaxed and comfortable. And so we were doing that. And she said, I asked her, what happened during the last appointment when you ran out? And so she said, well, my mom brought up what was happening in elementary school. And I feel so ashamed by that. And it really embarrasses me and it hurts my feelings. And I don't like to talk about it. And that's why she ran out. So there was also, changing therapists, and there's the other kind of like more common struggles for teens. But she's very aware. And I find that that's true for a lot of, you know, teens and women with ADHD who have flown under the radar. Like they have a lot of insight, they
Mhm.
know what's going on. It's just that I think the professionals are yet to maybe confirm like what they already know.
Yeah.
And, she kind of internalized that and she thought like I'm just out of control, I'm stupid
Yeah.
because I, just can't get my ducks in a row or because I can't do math, to the same capacity as like other kids.
And that really is where a correct diagnosis can be so helpful. I mean, I hear a lot from parents like, I don't want to label my kid. I don't want them to feel bad. They already feel bad. They already know they're different. And when we don't put a name to it, it makes it unmentionable, and unmentionable is unmanageable. And so when we do name it, and clearly that's the case for this girl too. It's like, this is a part of what happens to you because of the way your brain is wired. I call this brain talk sometimes. Like, this is
Mhm.
what your brain does. This is how it is. This is how it affects you. An on ramp for self understanding, self advocacy, and self acceptance in a way that not naming those things really isn't.
Absolutely. Yep. And I also, I had a moment like that with her where once she finally did get her diagnosis, I hadn't told her that I have ADHD.
Mm.
But there was this moment where she just, again, was just like, I think her mom said, like, oh, but it's very mild. If we're talking about the eval results, it's very mild, like her math diagnosis, right? It's mild. So then my client, like, again, burst out of the room. So we said, here, come talk to, Dr. Gilly, and then your mom will leave. So she sat with me and she said, if this is mild, then I must be an idiot, because this is really hard for me and it doesn't feel mild to me. So then I said to her, do you see that diploma on the wall? I have a PhD and I have ADHD too. And I also think I have a math disorder. So no, like, you're not an idiot. I think anyone who calls you an idiot is an idiot. And, you can be successful and we can talk about, how you can do that. She literally started crying and the shoulder. It was such a touching moment. And, I think things have just been like looking up for her, like, since then, because we can laugh about these little, quirks together. I think humor
Yeah.
makes a big difference for people. But when you can tack it on to like an explanation and say, this is hard for me because of my ADHD or because of this part of my ADHD. And now what can we do? So that way you can highlight your strengths and work with the things that are harder for you.
Yeah. Yeah. Oh my gosh, I love that so much. Gilly, if people want to learn more about you and your work and your book, where can they do that?
You can learn more about me on my website. It's drgillykahn.com. I'm also active on Instagram. My handle is Dr. Gilly Kahn. And yeah, if you want to find me on LinkedIn, Dr. Gilly Kahn also, I guess, like, when in doubt, that is that. But
Perfect.
yeah.
We will link to all of those in the show notes. And I want to thank you so much for being here today. This was a treat.
Yeah, of course. Thanks for having me on.